welcome everyone. Session 5, Spine Call, Know Your Neuro. Here we go. So what is AO Link? A webinar dedicated to medical students presented by AO Foundation, AO North America, getting everyone introduced to some foundational concepts. And so here we go. We got a message from Dr. Mark Lee, the current president of AO North America, who the leadership is so supportive of this initiative, and we are so grateful for that. So Amy Kapatkin, the AO North America chair as well within that. And so Dr. Aker here with us again tonight, our liege, our guide, as he guides us through the spine, or at least ask the questions that I want to ask, I hope. So I'm Phil Mitchell at Vanderbilt and Nashville and Taylor on the clickety-clacks, the ones and the twos, taking care of the question and answer box. He's been reading all week for this, back in the spine textbook, ready to go. So use the Q&A box for y'all's questions, and here we go. We have two amazing faculty tonight, and I'm going to have James Showery introduce himself. James, a little bit of your background, your training, where you did your residency and fellowship, where you're currently practicing, and then what got you interested in spine? What sparked your career in spine surgery?
Sure. So thanks for having me here. I'm James Showery, UT Houston. So I did in medical school at Texas Tech in El Paso, and did my residency at UT Houston with Dr. Aker, and also worked with the esteemed Dr. Mitchell as well. And did my spine fellowship at Cleveland Clinic, and then came back to UT as faculty. I mostly do, take care of a little bit of everything, but a large piece of my practice is spine trauma, including spinal cord injury and everything that comes in on the spine call, whether that's infection, tumor, what have you. The question of why do we select our specific subspecialty, I think has to do a little bit with mentors, but also a lot with, your kind of disposition in general towards certain topics. What I liked about spine is that there's a lot of instant gratification in somebody with a significant neurologic deficit or significant pain from, radiculopathy or disc herniation, even something that simple that's making them miserable. They wake up from surgery and they have less pain than they did before surgery. You have somebody with, incomplete spinal cord injury, you take care of them appropriately, they'll have almost immediate return of some of their neurologic function. And then too, it tends to be a little bit more stressful. And I think that I was sort of drawn to that complexity. Obviously I think that at heart, I was a trauma surgeon and trained to be a trauma surgeon. So that definitely influences my thoughts about how to deal with spinal injuries and my overall philosophy for taking care of these patients.
Nice. JP Wayner also with us tonight. JP, where you trained, where you are currently, and then what got you interested in spine, and maybe flat back or chin on chest. What's your favorite spine deformity?
Yeah, so I went to MCW actually for medical school, and then went down to Vanderbilt for residency, did orthopedic residency down there with the esteemed Phil Mitchell, and then I did my spine fellowship at the Cleveland Clinic, and crossed paths with James as well there. And then I had met my wife while I was at MCW, so we came back up here, and now my partner actually just left, so I'm kind of assuming the same role that my mentor did, as kind of the sole orthopedic spine provider at my institution, which also kind of leads into why I got into spine. And James alluded to it when he talked, and so much I think of whatever you choose, whether it's spine or any other subspecialty, so much of that is dependent on your mentors and the people you look up to when you trained with, and the experience that you had when you're on their rotation. And I mean, if you would have asked me halfway through my second year what I was going to go into, and you had said spine, I would have laughed in your face and said, absolutely no way. I thought I was going to be a shoulder elbow surgeon for a long time. Did some research before residency in that, and thought that's what I wanted to do, and had an amazing time on my spine rotation. And halfway through it, I was like, I don't hate this as much as I thought I was going to, and just really started enjoying every single day. And so much of that had to do with the person I was working with, Byron Stevens down at Vanderbilt. And I'm very grateful for him, because he kind of showed me the light. And like James said, I like the complexity. I like the fact that, I can look at an MRI and know some of the symptoms that the patient should have and kind of connect those dots and then be able to help those people. I like that there's a trauma component to it too. That was a huge draw for me and something that I liked and wanted to have in my subspecialty too. So it just kind of all came together and ended up being something I didn't really foresee, but really happy I got into. Oh, and then sorry, and favorite deformity is chin on chest for
Chin
sure.
on chest. There we go.
Yeah.
Well, thank you both for being here. We're excited to learn from y'all, hear some of the wisdom, hear some of the interaction. So here's our roadmap, hitting midway through. I'll highlight next week's residency interview session, same time on Thursday. So we're looking forward to that. Have some great faculty lined up for that as well. AO milestones, a plug for this module, which takes you through not only your medical student learning, but also as a resident as well. Ask a question, use the Q&A box. Watch again if they're on YouTube. Claim your Credly badge if you're collecting to get your merit badge at the end. Just a very quick recap. We did hand call last month, an unbelievable session. I think tonight is going to be even better. But these cases, if y'all want to watch again on YouTube, we went through a number of different types of cases. We went through this case, a traumatic laceration to the hand, talked about how that was managed, how hand surgeons use a microscope to repair tiny nerves in the hand and all the different structures that are involved there. We went through these different kinds of infection and pressure injuries and the management of these and how a tiny pressure injury may require a fairly large exposure, and the same for an infection. And then we went over some hand fractures and some screws, some intramedullary nailing of some metacarpals. So if you all want to revisit any of that, it's on YouTube. But we're going to move right into spine call, and this is designated or designed really for spine consults and how to approach spine consults when y'all are seeing them in the ER. And so we're going to talk about some fractures and recognizing patterns, and then talk about some other emergencies and infections. So JP, start us out, introduce us to spine. A medical student shows up to clinic. What are you telling them about what it's like to be on the spine rotation?
Yeah, kind of what we had talked about before, and I definitely felt this as a resident or as a medical student when I was first kind of introduced to spine, and there's a lot of trepidation, right? It's a little unfamiliar territory. It's a little different than any of the other orthopedic subspecialties, and so I think there's some fear that goes along with it. I think a huge portion of it comes from the fact that there are associated neurologic injuries, and those injuries can be time sensitive, right? So there's some urgency or emergencies that are not all that uncommon when it comes to spine. And so because of that, I think as a resident or medical student, you approach it with a little bit more fear than you would otherwise. And so I think hopefully this session will put some nerves at ease and realize that it's very much like any of the other orthopedic consults that you see. If you have a system in place, if you have your protocol that you follow and you do that consistently, just like you do out in the OR, if you do that with regards to consults, you're not going to miss things. You're going to make a lot of people better, and I think you won't face it with as much fear as maybe some people do initially. That being said, spine is difficult and can be complex. There's an adage that we say if you ask 10 spine surgeons, you're going to get 11 different answers, and there's true. So there's going to be some gray areas. It's not all black and white, and I think that's why it's important to kind of kick it up the chain if you're unsure, especially early on in your training.
So seeing a spine consult, you mentioned that having a systematic approach is essential. You have some other bullet points on here as well. So kind of walk us through some of the other pearls when you're seeing a spine consult in the emergency department, how to stay out of trouble.
Yeah, it cannot highlight enough the systematic approach. Right? If you every single time you see a patient, especially a spine patient, you do the exact same workflow, whether it comes to imaging or your neurologic exam, you won't miss stuff. You'll pick up on a lot of stuff that people don't see or didn't notice. And so I made it a point, especially in my training, to make sure that I never looked at any read from a radiologist before I went through imaging, and I approached it the exact same way, looked at the ligamentous structures in a very systematic way, and then looked at the bony structures, and slowly over time, I would then cross-check to see if I missed anything. And once you develop that system, I think you become very confident in it moving forward. And it goes the same thing with the neurologic exam. You have to know when you call your senior resident or you're attending, you need to know that exam stone cold, because for spine, it's absolutely crucial to know that. And it can change, operative plans very quickly. And so be confident. Don't walk out of that room until you're confident and know exactly what their exam is. We touched on this a little bit earlier. If you're unsure, we realize that spine's a little foreign to some people, so bump it up. Get people on board early if you're not sure. Don't wait. That's when people get in trouble and patients get hurt. One of the things that I always was taught is make sure you assess stability on standing upright X-rays. So we may say an injury is stable, but we don't know that until we can demonstrate that. And the way you demonstrate that was just standing upright radiographs. And so never let a patient leave the hospital without obtaining those and seeing that there isn't any translation or movement, because again, people can get hurt quickly. And just in that same thread, there's snakes in the grass. Respect all injuries. Don't, just because it's a spinous process fracture and there's nothing else, don't assume that that's all there is. Make sure you always have your antennas up, and I think if you do that, you're gonna help a lot of people.
Dr. Shower, anything
JP,
to add to that?
yeah. So JP, when you were learning, spine anatomy can be challenging. In some ways, it's very repetitive, but in a lot of ways, it's very unique. And it's unique and it changes and it's sort of dynamic throughout the entire spine. How did you study for anatomy for your spine rotations? Like, how did you? Those are kind of the main points that we're going to be asking med students. Is typically, anatomic questions. We expect them to know that. How did you
Yeah, I
study
mean,
for it?
Yeah, I mean, I think there's the initial approach or the initial step, which is you just have to know the anatomy. So you need to read and continue to read and keep reading and never stop reading, because I think that's where you pick up a lot of that information initially. And then kind of what I talked about, you have to there's book knowledge and then there's experiential knowledge. And the only way you get the second half of it is by seeing consults and working through imaging, and doing it in a systematic way. And so I would always look at the CT scans first. You're looking at, as soft tissue planes. You're looking at making sure that the alignment is consistent throughout. You're comparing one side to the other side, seeing if there's any asymmetry. I have a very systematic flow for every ligament I would look at in the same order. And like I said, I would never look at the read, because if you look at it, I think you take your lens and you focus it on a single area and you start missing things. So um, read, see as many patients as you can, and you'll continue to improve.
Maybe to that point, James, this is kind of some intro to spine anatomy. So what bare essentials are you expecting from a bony standpoint for a medical student to know when they walk into your clinic? I've put some colored arrows on here so you can use those maybe to indicate.
Yeah. So, kind of key things that I would expect medical students to know is just being able to look at an X-ray and identify what part of the spine we're looking at. I mean, that sounds really simple, but it's easy to be confused about that. And then two, understanding what is normal and what is not normal. So, here we have a diagram of these are thoracic vertebrae, and you can tell that based on the alignment or the angle of the lamina and the orientation of the facet joints and things. And as you can see, there's costovertebral joints. Here we're looking at this blue arrow is highlighting the pars, which connects the inferior articular process to the superior articular process. The yellow line is pointing to the facet joint, or the zygoapophyseal joint, which is the joints that connect the posterior aspect of the spine. And then obviously the red arrow pointing to the vertebral body. And then, here we can see the intervertebral disc, the spinal cord, and exiting nerve roots. The things that I expect med students to know as well would be how you label the nerve roots. So how you label a nerve root exiting in the cervical spine versus how you would label a nerve root exiting in the lumbar spine, and kind of the anatomic arrangement of that. So in the cervical spine, at let's say the C5, C6 level, it's the C6 nerve root that exits, meaning the nerve that exits The nerve is labeled after the vertebral body that's just below it. In the lumbar spine at L4-5, it's the L4 nerve root that exits between L4 and L5. So it's the nerve root is labeled by the vertebral body that is above it. This has to do with, basically the anatomy of where the nerve roots exit, starting from occiput down to C8. And obviously something you all will go through during your anatomy courses, but something to keep in mind, and something that I think is very important for understanding at somebody's exam based on and correlating it with their imaging.
JP, you mentioned ligaments a few times and a systematic approach. So what ligaments are important? Dr. Showery just went through the bones that we're going to talk about, and some are going to continue to come up, and you'll hear facet and superior articulating process. And what ligaments on this diagram should students be paying attention to as we are about to go into the first fracture case?
Bill,
Yeah, sure.
let me just interrupt, because I love that comment, because students going into orthopedics already know that orthopedics is a little bit of a different language. Like your gross anatomy and your inferior vena cava and all the stuff that they learn as students. Orthopedic anatomy is a little bit different. It's more in depth, it's more in detail, and they're worried about the ACL, the PCL, where does it connect, and the MCL and the Tommy John surgery. Then you get in the spine, it's like, oh man, it's a whole nother textbook of language and vernacular and structures. So this is very intimidating, but it's a great reminder. It's the information is out there, and this, if you just think about it in a systematic way, you break it down. In the front of the vertebral body is here, the back is here. Just slow it down like these guys are doing, explain it, and it all makes sense. It all makes sense. So strong work.
All right, JP, what you got? Left image here. Few
Yeah,
ligaments.
so there,
Are these important, or are these just accessory vestigial organs like an appendix?
no, it's definitely all are important, and it's easy to there's a classification system where you can break it down into three columns of the spine. So there's the anterior or the middle column, and then the posterior column. And so the anterior column is going to be the anterior 2/3 of the vertebral body, as well as the anterior longitudinal ligament. So if you look on the far left image, the blue box outlines the anterior 2/3 of the vertebral body and the anterior longitudinal ligament. So that's going to be the anterior third, or 2/3 rather. And then you have your middle column, which is going to be the posterior third of the vertebral body. And then you can also see, kind of sneaking up behind the vertebral bodies, is that posterior longitudinal ligament that's outlined in the red rectangle on the far left image. And then if you go to the far right, there's outlined in the yellow box, the posterior column, and that's going to be your posterior ligamentous complex. And so there are a lot of ligaments in the back. The interspinous, if you just break down the word interspinous, so it's between the spinous processes. The supraspinous, again, break it down, it kind of runs along the dorsal aspect, or the top of the spinous processes. And then you have your ligamentum flavum. The ligamentum flavum is a kind of complex structure, and understanding its anatomy can take a while to fully understand it, but it's a very important structure, not only when you're operating, but also when you're trying to assess stability. So that runs along the ventral aspect of the lamina, which is the bridge of bone that kind of protects the spinal canal. And so there's also the facet capsules as well. So James kind of talked about the facet and superior, or facet, and then if you say superior articular process or inferior articular process or superior facet, inferior facet, those all mean the same thing. So if you say superior articular process or superior facet, we're talking about the same thing. If you're talking about inferior articular facet or anterior articular process, those are the same things. They're synonymous. But the capsule around those facet joints is also very important. And so you're looking for gapping anteriorly, posteriorly, seeing if the fracture extends between the anterior, middle, or posterior columns. You're looking for if there's any distraction, translation on these injuries. And that's the first way to do it, is identify what's normal, identify what's not normal, and then try to describe it as best you can. And again, repetition, and this will become a second language to you.
I think also
Awesome.
the three column model was sort of an early attempt at understanding spine stability back in the early days of radiology and treating these patients. So, it sort of has this logical progression of a one column injury tends to be more stable than a two column injury, which tends to be more stable than a three column injury. So three column injuries are real bad usually, and a one column injury usually is kind of nothing, so it just depends on that. There's a lot of different factors, but I think that this is a good framework, and it branches off into every other classification system that there is for spine trauma, whether it's the TLIC score, which kind of morphed into the AO spine classification. They're all sort of predicated on this fundamental understanding of the spine alignment and or spine anatomy and how everything connects together. I think too, understanding anatomy for medical students going into surgery or when they're in the surgery, you're really only visualizing the back of the spine. You get that kind of center view that we're seeing here, and there's lots of muscular attachments everywhere. So you're not really seeing the whole thing. You get a very limited view. And hence it's really important to understand the osteology, like how the bones are connected and aligned, the angles of the pedicles and all that. Obviously more important for actually performing the surgery, but in order to learn that, one thing that was very helpful to me was just spending a lot of time with a three-dimensional model, getting Sawbones model and just studying it and really kind of poring over it, letting your brain just kind of absorb the details that you can, and then try to describe the details that you see. And that'll serve you well when it comes time to identify, random anatomic landmarks when you're in the middle of a case.
Speaking of cases, let's apply the anatomy. So this is the first case, 29-year-old MVC polytrauma. At the scene, intubated by EMS. There's a spine consult for a C6 process fracture. We've got a little bit of a limited exam, James. This is your case. 3T with no rectal tone, some other orthopedic injuries, and some other traumatic injuries. But what is this no rectal tone and a C6 spinous process? We're not showing the imaging quite yet, but what are you worried about?
Yeah, so this is kind of a common scenario. You're on call, you get a phone call from a trauma resident who doesn't quite understand what's going on either, and they're telling you some information that should be a little bit raising your antenna. So they say a C6 spinous process fracture. That ordinarily is not that significant, but this patient they're telling you has no neurologic exam. They're GCS 3T. They're not responsive. And then the only objective piece of data about their neurologic exam is that they don't have any rectal tone, which tells you that this is possibly a spinal cord injury. So obviously looking into their imaging and sort of expediting this on your triage of things you need to do. This is like number one on that list almost immediately. So you pull up the CT scan and you're looking at it right here and you see the sagittal cut of the cervical spine. We talk about being systematic about how you're looking at imaging. You don't want to just go to what they told you the fracture was. I'd recommend starting always with the cervical CT. Started from the sagittals of the cervical CT. You'll see about 80% of the injuries in the cervical spine or in the entire spine just by starting with the sagittals. So in a systematic approach, look at the top first, right? So make sure the OC, C1, C2 joints are okay. And then this yellow circle is identifying the beginning of what we're seeing as part of this injury. We're seeing a small fracture of the C6 inferior articular process and facet, and a little bit in the C7 superior articular process. In the next view, we can see that C6 spinous process and lamina fracture. And then you can also notice the anterior longitudinal line, which is a line that connects the front of the vertebral bodies. And this should be in continuity. It shouldn't be discontinuous anywhere. And when you look at this carefully, you'll notice that there's discontinuity of the anterior longitudinal line and a spondylolisthesis or anterolisthesis at C6, C7. And this is more concerning because now it's telling me that this is an unstable injury. These facet fractures in and of themselves, typically with a fracture that size on that one view we have on the left, many times that can be a stable type injury. However, we're starting to see some instability here on the mid-sagittal. And then finally, on the other parasagittal view, we can see that there's a more comminuted C6 facet fracture, as well as a more subtle T1 and T2 superior and inferior articular facet fractures, as well as small compression fractures in those vertebral bodies.
Can you go back real quick, or maybe on this middle one here? You're saying C6, but if I counted that, I'm not sure that I count 6 individuals there. I think that can sometimes be confusing for students. Maybe how do you know what level is which level there?
Yeah, so that really the long one that kind of looks like a thumb, that's
Yeah.
C2, right? And C1 is like a ring. So this is the atlas and the axis, right? So the axis sits on top of C2 and rotates around. And this view here on the side view over here on the right, this is a 3D model of what that would look like if you were looking at a model of the spine. So when you're looking, you can pretty clearly identify C2. That's always a unique anatomic landmark, and I'd recommend starting to count, basically count down from there. So that's the best way to identify it.
Yeah,
So
the upper cervical, and I think one of the good ways to kind of just in your mind to classify it is upper cervical, so C2, and then above to the occiput, ultra complex anatomy. There are a ton of ligamentous structures that contribute to stability and understanding alignment and spatial relationships is a whole nother kind of aspect. Subaxial is going to be C3 and below. Subaxial spine can be grouped together because the anatomy is very similar. So when you're looking, that C3 is that first vertebral body that kind of looks like all the rest of them. And then anything above that C2, C1, and then the occiput. And like I said, I think probably upper cervical injuries are probably a little bit outside of the scope of what we're talking about here today. But I think if you can start in the subaxial spine and understand the anatomy and some of the instability that we're talking about, that's probably the best place to start.
Yeah. And then here, this slide just highlights the importance of retaining the injury. So what I mean by that is itemize and list all of the injuries that have occurred, right? Because it's not this, you can sum this up as this is a C6-7 facet fracture dislocation, or you can kind of identify all the pieces of this and how that pertains to what you make as your final diagnosis and what you need to treat. It's very easy to miss, kind of more subtle injuries that may affect treatment. For example, in here, this T1, T2 compression fracture with that facet injury at T1, T2 could potentially change what treatment you do and how much instability there is in this fracture. For this patient, it really didn't, but it's still very important to understand it and not get distracted by the most obvious injury. Look for the other little ones too that might affect what you do. I would say this is almost analogous to like the looking for a femoral neck fracture when you have a femur, like diaphyseal femur fracture. It's looking for the other things that could change what you do or lead to an early failure.
I think it's an important point, and as Dr. Young and Dr. Naker and I like to show our most violent, destroyed, traumatic injuries. These look like little cracks here and a little widening there, and I think that's why there is fear at times with spine. You included this image of the same patient, Dr. Showery. So kind of what are you seeing here? Why did you include this image? What does this reveal to you?
Yeah, so one thing that I learned in my residency, which was just so important, is looking at everything in your image, and that includes your retroperitoneal structures, and you're looking at pelvic ring injuries, looking at other parts of the anatomy. In the spine, there is about a 20% chance of having non-contiguous fractures after a one fracture somewhere in the spine, right? So you always want to get complete spine imaging on anybody with a spine fracture. You want to have cervical, thoracic, and lumbar spine CT if you know there's a fracture. This also shows that it's really important to look at all your imaging, right? So this patient went back for another CT chest, abdomen, pelvis, and in that scan, their C6, C7 dislocated further, right? So now it's grade 3 anterolisthesis. And this is telling me that this is a very unstable injury, that even just moving somebody from a table back to the CT scanner, they're translating significantly. And in that setting, that is a high risk for worsening their spinal cord injury, which is already a very devastating condition.
Yeah, and so we're going to get into the AO classification on the next case as well. But James, maybe a takeaway for how to put this within one of these categories, A, B, C, type?
Yeah, so the AO subaxial injury classification is very complicated. But if you break it down to the elemental pieces of it, it's sort of A's are not so bad, right? B's are a little bit worse. They're a tension band injury, so disruption of the posterior ligamentous structures without any translation. And C's are the bad ones. So a C injury is some sort of translation or rotation, and these patients are much higher risk for having a spinal cord injury compared to the other two. Much more likely to be unstable. In fact, by C is defined as being unstable.
Nice.
So the trauma resident says, "Hey, this patient's going to the OR emergently for an XLAP. What do we do?" So I would say for any resident, that's in the scenario, first thing you need to do is go get a physical exam, right? Don't trust what they just told you. Go examine the person yourself to understand what's going on. So that includes your primary survey, just looking at them, right? You want to immobilize their cervical spine, whether that means making sure they have a collar on or sandbags behind on the sides of their head to limit motion. Alert the team that's taking care of this patient that they do have a significant unstable cervical spine injury, because when you turn and move a patient, if they're continuing to shift and sublux like you're seeing here, it worsens their spinal cord injury. So getting a detailed myotomal strength exam, as best you can, getting a good dermatomal exam as well. Obviously checking for erectile tone, bobocavernosus reflex, those things. You want to log roll the patient and palpate their spine while maintaining C-spine precautions. All these things are really important. And in something like this, you want to very quickly escalate this, to whoever's going to be making the decision about what we're going to do next. And the last piece is like, do we get an MRI, right? So in this situation, they're an extremis. They're hypotensive. They have a retroperitoneal bleeding. They need an XLAP to save their life. So you can't get an MRI. You just have to, know that there's likely a spinal cord injury, unstable injury. MRI won't change what you're going to do anyway.
Yeah. So for this, the plan you noted here is closed reduction with Gardner-Wells tongs. And so maybe you can walk through just what is needed for something like this. Is this a device that your residents are putting on in the ER? Do they ask you about putting on Gardner-Wells tongs beforehand? Kind of walk us through this scenario here.
Yeah, so while our residents are usually involved in this process, this is also, generally speaking, an attending level process or procedure. So for most situations, you'll have an attending with you for this part. But the way to stand out as a medical student on your away rotations or working with your home institution is to know what is going to come next and potentially what tools you need to gather, right? So you're going to need Gardner-Wells tongs, which are what you see here. You're going to need a lot of weight, so a lot more than you'd put on for a femur traction or a acetabular fracture or something like that. You're going to need about 60 to 90 pounds. So typically it's about 10 pounds per level. So at a C5-6 dislocation, you might need 50, 60 pounds, sometimes a little more, depending on the size of the patient. You're going to need a rope and a traction frame. You're going to need C-arm or X-ray to be able to take X-ray as you're doing the reduction. And two, you're going to need the ability to do a conscious sedation for this patient in order to complete this procedure. And this is if it's done in the ER, but this can also be done in the operating room.
Just to clarify, this is if there's a dislocation, like that image that showed the vertebral bodies kind of sitting, dislocated with the facets dislocated. That's Gardner-Wells tongs. If somebody just had that initial image with the facet fractures and a little bit of offset, would they get Gardner-Wells tongs too, or is that a sandbags on the side of the head situation?
No, that's a very good question. Usually that's just a sandbag side of the head, but traction, because of the function of the ligament ataxis that occurs, there's still some intact ligaments, and usually a small amount of traction can be enough to kind of hold the spine in a relatively reduced or non sublux position. You got to be really careful depending on how much instability there is, and it's really important if you're doing traction for something like that where you're worried about a lot of ligamentous instability, to take X-rays as you're doing it. You don't want to over distract somebody and potentially worsen their spinal cord injury.
Because then it would pull tension across their spinal cord.
Correct.
Could worsen their injury. Gotcha. So here's some clinical images of this patient with the Gardner-Wells tongs on, the traction, the drape. Dr. Wayne, or anything to add to what Dr. Showie was walking through there?
No, I mean, I think, he's pretty spot on with the way that this goes. Just as a technical point, the facet joints, they're angled like shingles on a roof at like 45 degrees, right? So when this patient, and in this case, there's bilateral fracture, so it makes it a little bit easier to reduce. But the whole point of this is that, through the fracture, or sometimes not a fracture, just a dislocation, that facet jumps over the other one, right? And so then it can kind of get locked in place. And sometimes these reductions are a little bit harder. So the goal is first to distract through, right? And you're trying to get those facets back over the top. And then once you get the facets kind of back over the top, a lot of times you can do that with a little flexion moment and the traction. And then once you get them back over, then you bring it and just go straight axial traction. And so that's kind of just the thought behind this. We're not just pulling straight on somebody's neck and wait until it pops over. Those facets are at a 45-degree angle. The one is in front of the inferior articular facet is now in front of the superior articular facet, and we need to reverse those again. And so again, you want traction, a little bit of flexion, bring it back over the top, and then just straight axial traction to kind of hold it in place.
For this patient, we did this isn't pictures of this patient in particular, but just pictures of this procedure. But for this patient, we applied the Gardner-Wells tongs and traction to make sure the neck stayed in a relatively reduced position during the X-lap. So while they were prepping a draper for the X-lap, we put on a little bit of traction, checked it, make sure the neck was in a good position and not dislocated, and then waited for them to finish, and then proceeded to fix it with an 6-7 ACDF with plans for posterior stabilization when they were clinically stable. I think an important and learning point from this case is that this patient subsequently developed a bilateral, flail chest and pneumothoraces. They were intubated and sedated for a long period of time, and developed acute respiratory distress syndrome. And they were unable to go to the OR due to their vent requirements for about 8 weeks. So this patient with this is sort of our one shot to stabilize this the best we can, because they're not going to be able to tolerate another procedure. So hence the sort of importance of knowing about this right away, getting this taken care of while they're in the OR, and then before everything else kind of snowballs into a situation where we're unable to take care of them effectively.
Was that done in the middle of the night, James, or like?
Yeah, 1 a.m., 2 a.m. or something like that.
Yeah, I think it's a remarkable case. Incredible instability. Initial fractures don't look so bad, but then have the opportunity to, during the X-lap, place the Gardner-Wells tongs because the instability, just with transferring, things are shucking around, you can stabilize, and then do this, which is going to provide stability to hold things reduced instead of being in Gardner-Wells tongs, or I guess a halo or something, for 8 weeks when they can't go to surgery. So really a tremendous case to show there. Taylor, any questions from the Q&A box?
Yeah, that's actually an excellent segue into one of the questions about how you can temporize cervical spine injuries when patients are going to the OR emergently. In this case, obviously, it's probably a more rare instance where you're going to put somebody in Gardner-Wells tongs because of the dislocation there. But in general, would you say that the standard would be a C-collar and spine precautions most of the time for like dislocated or wildly displaced injuries?
Yeah. I think even it depends on some of their neurology too, right? So if you have a patient with a unilateral facet dislocation and neurologically intact, a cervical collar will be enough to protect them while they have their life-saving surgery. And then you can consider doing the reduction after the fact. The more unstable, the more likely you are to have to do a more invasive approach, right? So sometimes we mentioned halo as an option for some people, and in a situation where they have significant upper cervical instability, or otherwise it might be a good temporizing option as well. So in addition to traction, usually traction is good on the spine unit, but it depends on the type of injury. And it kind of, some situations, maybe a halo would be another more, stabilizing tool other than the cervical collar.
Yeah,
I think it's important too. Cervical collars are people are as different on the outside as they are on the inside, and the cervical collars are not a one size fits all thing. So you have to be mindful of the kind of injury that they have. So if somebody has a stiff spine from an ankylosing spine, and they have an extension type injury, many cervical collars can force their neck into more extension. And sometimes it requires placing a bump under the head or something else to kind of hold it in a reasonable position for, during transfers and other things like that, until a patient is able to go to the operating room.
Nice.
Yeah, that's great. And then what about timing of reduction in those cases, in cases like this one?
Yeah, so in someone with a spinal cord injury, we know that early reduction and decompression improves neurologic outcomes within 24 hours of their injury. So there's some evidence to support ultra early decompression, improving neurologic outcomes even in patients with complete spinal cord injuries. And many of these people who present as a complete spinal cord injury, meaning that they have no motor or sensory function below the level of injury, will convert to an incomplete spinal cord injury. And any improvement, even in 1 or 2 myotomes, even in a little bit of sensation, is a major difference for them. So, most major trauma centers tend to treat highly unstable cervical injuries, especially with any kind of spinal cord injury, on an emergent basis when possible. um, you know, the patient who is neurologically intact with a potentially unstable injury, as long as they're remaining neurologically intact, you can potentially wait a little bit to do it. It doesn't have to be in the middle of the night surgery. And depending on how complex the surgery is, sometimes going in the middle of the night, even if it might get them fixed sooner, right? You're now dealing with a team that is not as familiar. You're dealing with X-ray techs who may not be as familiar, and may just take longer, and maybe higher risk for complications and things. So all those are factors that play into my decision making when I'm deciding, does this need to go now, or can I wait? Can I wait till the morning?
We're going to transition to the next case. Again, a phenomenal case, James. There, JP, this is one of yours. 42-year-old fell downstairs with neck and mid-back pain. Neuro exam, normal, 5 out of 5. Outside of some little bit of numbness in the C7 distribution, no other injuries. I'm going to jump straight to the imaging and just walk me through this. We just went through some cracks in the facets and some widening. What are you seeing on these image? What stands out to you?
Yeah, no, so I think this is a good case to kind of contrast what James showed. So if you on the far left, it's a mid-sagittal cut of the CT of the cervical spine, and then there's the left parasagittal in the mid, and then a right parasagittal on the right, far right. The first thing that I hope medical students and residents start to notice between what James just showed and what this shows is that there's a tremendous amount of ankylosis or autofusion in this spine. So if you look in the mid-sagittal, you can see it through the lamina in the spinous process in the posterior aspect of the patient's spine. And then if you look in the anterior aspect, it's kind of fused through those discs, right? Before James that showed on the CT scan, there was space between each of those vertebral bodies, and that indicates that there's still motion through there. Here, it's kind of essentially what this equates to is a long bone type injury or long bone fracture, because you can see widening of the disc space. There's only really 2 disc spaces within that subaxial cervical spine that are still quote unquote open or have movement through them. And then if you look on the the left parasagittal in the middle there, you'll see the facet joints that we talked about, those shingles on a roof, those are now glued together. There's no movement through those joints anymore. That's just one big block of bone, except at that C5, C6. I know it's not labeled, but C5, C6 in the middle image, you kind of see a little bit of a gap between the two. And so there's some motion at that level. And then if you look at the far right image, you're seeing that gapping again in the facet at C5, C6, but you're also seeing a fracture through the pedicle down at C7. And so As kind of a description of the fractures, the biggest thing, especially early on, that you need to notice is the ankylosis. It's fused almost all the way up the entire cervical spine. What that does is, before, there's motion at each of those levels, right? And so when any kind of energy travels through the spine, through either the traumatic event or moving them from one bed to the other, it can dissipate through all of those levels, right? So in this one, it cannot move anywhere except through the fracture sites. That is the only motion in this spine, is through the fracture sites. And so it makes this injury incredibly unstable and has a very high potential to do what James showed in the first case, which is displace with even just movement from one bed to the other. And so this type of patient, this type of CT scan, you need to be able to differentiate from what James showed, and then you also have to be able to understand and kind of have that raise your antennas that this is an unstable injury, and you need to kind of let the entire treatment team know, because unfortunately you can't follow this patient, in every little aspect of their care.
So the next image you included was a thoracic, and based on that description, I think I'm seeing another. Am I seeing a segmental spine injury here?
You are, which is
Okay.
not uncommon for these extension type injuries in ankylosed spines. And so, one of the points that we want you guys to understand after this is especially with trauma, an ankylosed spine is very true, but infection, tumor, almost all these cases, you want to image the entire spine. There can be skip lesions, there can be non-contiguous injuries, especially in a stiff spine like this. And here you can see that, again, it's not labeled, but I think it's the T9, T10 disc space. There's clear anterior gapping, right? It's fused above, they call it a bamboo spine, fused all the way above, fused below, and the only motion is now through this one disc space. And so again, it kind of, you can think of it in a way, I think of it as almost like a broomstick. If you crack a broomstick in half and then try to stick those two ends together, that's incredibly difficult to do. And if you just blow on it, it's going to fall apart. And that's kind of that's how you have to understand or think about this injury.
Nice. So here's the MRI scan showing and reflecting some of the disruption. I think we'll see a few MRIs as we go along as well. The arrows pointing out the injury to some of the ligamentous structures. And again, the AO classification, for the sake of time, I'm going to go kind of blow through this a little bit. A-type, compression type injuries, increasing in severity. B-type, these distraction injuries. And then this one, I guess, JP is a B type, but is still unstable. So it's not a C, but B and some A's still need surgery too. Is that accurate?
Yeah, the A's can be a little bit more complex depending on, like A3/4s, stuff like that. But for B types, they're distraction injuries. So it's a tension band injury. So it's either anterior tension band fails in extension, which is what we just saw, which is a B3 injury, or it's more of a flexion distraction injury and the posterior tension band disrupts, and that's a B1 or B2.
Perfect. And then the C type, which James showed before in the case prior. So there are algorithms out there to be able to follow and look through as y'all are looking at these images. Bring it all together for us, JP. Diagnosis, and then ultimately, what's this treatment of this patient going to be?
Sure. So kind of the process that caused the ankylosis or the fusion of the spine to begin with was ankylosing spondylitis. Another autofusion that you'll see a lot on call is called DISH spine, or diffuse idiopathic skeletal hyperostosis, something that you guys should be aware of. But those are the two main ways for a spine to become stiff. And then it's extension injury. So this is a B3, C5 to C7 had an extension injury, and then a non-contiguous one down at T9, T10. As these are essentially long bone fractures, you're not gonna treat a transverse femur fracture with a 4-hole plate, right? You're gonna need a much longer construct for that. So this is a long bone fracture. You need a long fusion segment, which is what this patient got. 3 above, 3 below for the thoracic injury, and then the same for the cervical injury.
Nice. So to sum it up, ankylosing spondylitis, dish spine, these are much different than that first case and much more unstable, and like that last image may require or will require a long segment fusion. So
JP, it seemed like we had several questions asking about anterior versus posterior stabilization. And I think these are kind of interesting contrasts between the two cases. So when, how do you decide whether or not to do an anterior approach for this patient first for the cervical injury, and how does that play a role in your posterior stabilization? Like, when are you deciding to also stabilize posterior after going anterior? When is posterior alone enough? When is
Sure.
anterior alone
Yeah.
enough?
So for stiff spine fractures, again, they're a little bit different than maybe some of the other fractures that we have talked about or will talk about. But for stiff spine fractures, AS or dish, I'm almost always going in the back because I'm doing long segment fusions. The cervical procedure that I did here was a posterior. I'm not going to lie, it was it's a clinching moment when you're flipping this patient over, and you're trying to do that in a very controlled fashion because those can displace. There are some people that will go anterior, kind of do an ACDF quickly, throw a plate on there to add some stability to it, and then go in the back. Anteriorly, it's difficult to do long segment fusions, and so for most of these, I'm going in the back and doing 2-3 levels above and below the fracture site.
Nice. We'll
I
get
think
on
the
to
other
that.
consideration too is in patients where you're going anterior and posterior, the risk that they remain intubated after surgery is much higher due to airway compromise. This is a long surgery. This takes probably, I don't know, probably took 5 or 6 hours even, and that's assuming he's a real fast. How long? 3 hours? Yeah, it takes a long time. So if you do an anterior approach on this patient, and then you put them prone, and they're prone for 6 hours, I mean, that they're going to have significant airway swelling and neck swelling. The odds that they get extubated right after that surgery is much lower. So some of that plays a role in some of this decision making as well.
Nice. All right, on to the next case. 62-year-old female presenting with some infectious type symptoms: fever, altered mental status, hypotension, and then some paresthesias and weakness. Showery, this is one of your cases. What on the exam is important? What are you looking at that's piquing your interest here, that's making you think that actually I may need to operate on this person or follow them a little bit more closely?
Yeah, this is challenging. I mean, this is a patient who's presenting with sepsis, right? They're hypotensive, have a fever, altered mental status. Sometimes it can be very challenging to get a good neurologic exam to understand, do they really have weakness, or is this just they're just sick and not really following commands well? In this patient, she was pretty clearly, had anti-gravity strength to her upper extremities, maybe a little bit stronger to her lower extremities, but was reporting diffuse paresthesias, like sensory changes throughout. She had urinary retention, but intact rectal tone, and most importantly, she's disoriented, she is hypotensive, and she's tachycardic. So this is like a infection sepsis picture, based on that. The important thing too, we look at neurogenic shock versus septic shock. In a neurogenic shock patient, somebody who has had a spinal cord injury, and they will typically become hypotensive, but they'll be bradycardic as well. So they'll have low heart rate and low blood pressure, and that is a byproduct of loss of sympathetic tone from the spinal cord injury. Whereas this patient is basically has loss of peripheral vascular tone from the septicemia, and therefore, but they still have the ability to compensate by becoming tachycardic to support their blood flow.
So here's the CT scan. Does anything stick out to you on this, Shower? She's weak, but she's altered. So like, how do we really know? There was some urinary retention, but what what does that mean in somebody who's septic already? I guess, how are you bringing that picture together with this to then be concerned enough to get additional imaging or workup?
Yeah, so we're looking at this. When I look at the CT scan, and first glance from far away, looks a lot like just a degenerative spine, right? On the cervical spine, you see a little bit of disc height loss and stuff. But if you look very closely to the anterior soft tissues, there's a little bit of anterior kind of stranding that you can see, and sort of that'll be much more apparent when we show the MRIs at the. This patient's previously had an L4-5 fusion that happened many years ago. You can see that there's some sclerosis at the end plate at L2-3. And sometimes that can be, common with osteomyelitis, discitis. And then lastly, when you're looking at the axials, you can see a very subtle finding on the soft tissue windows of a small psoas abscess. You can kind of see just a little bit there, and we'll highlight those right now with the The
Nice.
next slide. Yeah, it's really subtle, hard to notice, easy to miss that on the CT scan. So obviously we get an MRI of the whole spine with without contrast to look for, infection and possible causes for her issues.
So different
So
kinds of spine infections, I guess, for this. Give us some takeaways for how to approach a patient like this.
yeah, so there's a lot of this is kind of the main groups of infection. So epidural abscess, these tend to be acute, kind of rapid onset, and they cause spinal cord compression and acute neurologic changes. Discitis osteomyelitis can be acute, subacute, or chronic. These will typically cause more pain and instability and sometimes deformity. Facet septic arthritis is less common, but people will have pain related to that. And obviously a postoperative wound infection, which unfortunately, can happen, but that's a little bit more obvious. Draining wound, instrumentation that's loose, that kind of thing.
So Batson
Um,
plexus, I think maybe something, if you could sum it up in a few sentences, James, how does this play into spine infection?
Yeah, sure. So Batson's plexus is implicated in the spread of metastatic disease and of infection. So what it is just a plexus of valveless veins that have slow and often retrograde flow around the spine, and they go into the epidural space, into the vertebral bodies, and right and feed outflow into the disc space. And in these kind of slower retrograde flow, it's an opportunity for if a patient were to develop septicemia, it can seed these areas. So the disc space is avascular, and bacteria likes to grow in an avascular environment. So the disc will typically get infected first, and sometimes the epidural space as well. Contrast this to metastatic disease like a tumor or lung cancer, for example, or prostate cancer. Because the cancer likes blood flow, it's going to stop and seed in the vertebral body itself. So infections go to the disc, tumors go to the bone is one way to kind of separate these two out in your mind. The discitis will then progress to osteomyelitis, affecting the end plates in the bone. And then at the same time, or kind of in sequence, a patient can develop an epidural abscess, which becomes more of an urgent condition to treat.
Great. So
Um,
I think for the sake of time, I'm going to put this slide up for workup, just showing that an MRI of the entire spine. And you mentioned that before, looking for skip lesions. So maybe you can describe skip lesions as I start to flip through some of these MRI cuts. What does that mean?
Yeah, so skip lesions are where you have non-contiguous infectious process in the spine. And this patient is, I think, a good example of that scenario. So I kind of show the T2, T1 post-contrast and CT here to just demonstrate that you really can see these findings that are really very obvious on the post-contrast CT that identify the infection and epidural abscess. And if you look very closely on the soft tissue windows, here in the cervical spine, you can also see that on the CT, that there is something going on there. Here you can see extension of the epidural abscess and some paraspinal abscess at T1, T2. That central port, you can also see evidence of osteomyelitis discitis at T9, T10, with some compression of the spinal cord, and then extension of the epidural abscess down to the L1 level. And then this patient also had abscess extending into the lumbar spine right here. And you can see that highlighted here where there's this, what we would call this nearly a holospinal abscess with infection into the paraspinal soft tissue, and bilateral psoas abscesses as well.
In this highlighting the psoas abscesses, and we get to the enormous diagnosis list. So what would you do for this spine here that's filled with pus?
Yeah, so the most important thing here is to get pressure off of their spinal cord as quickly as possible. So for her, the worst pressure on her spinal cord was at the C3-4 level with a ventral epidural abscess. So we did a 3-4 ACDF, and then followed by posterior cervical laminectomy, thoracic laminectomy, and lumbar laminectomy to evacuate the epidural abscess.
Can you
And
wash between those different laminectomies?
So we did, in this case, we did the ACDF. We did the first two parts of this, or really ACDF laminectomies and instrumentation removal, all at the same time. So ACDF first, then flip, and then open everything up to evacuate all that. Ultimately, because of the infection burden in the soft tissues in the back, we did serial wound vac exchanges and irrigation INDs to get her to clear her infection, and then subsequently re-instrumented the cervical spine posteriorly to achieve stability.
Nice. And then she gets her infection treatment, some directed antibiotics, some abscess of the psoas drains. And then here's her outcome at 6 months. Again, pretty remarkable. Is this normal? Is this what you expected, I guess, with such extensive infection in her spine?
Yeah, she not really, and she had a really good outcome for how bad her problem was. Many of these patients, I mean, with someone this sick, and this much infection burden, I mean, it's a little bit touch and go. Many of these people can succumb to that extent of infection very quickly. It's a life-threatening condition, beyond just a neurologically threatening condition. So she has fortunately done pretty well considering.
Awesome. So we're going to go a little over tonight, but I think it's indicated because we're hitting on the last two, maybe most common consults that you'll get. And so we're going to get cauda equina right now. So JP, a case of yours, cauda equina. Tell us a little about this patient and then an approach to cauda equina, because I feel like it may be a nightly occurrence
Yeah.
here, that somebody's worried downstairs.
Yeah, no, exactly. I think if this is going to be one of the most common, at least initial pages that you guys get when you're on call is concern for cauda equina syndrome, because uh, undoubtedly they'll ask, do you have any bowel or bladder dysfunction or symptoms? Everybody over 65 will say that they urinate themselves, and then all of a sudden this becomes cauda equina, and you're left with trying to parse out the actual information from what's truth. And so I think you have to have a few things. You have to have kind of imaging findings that are consistent with cauda equina. So there has to be essentially a complete obliteration of the thecal sac below the level of the conus. So the conus usually ends at L1, L2. But beyond that, it's not a spinal cord anymore. It becomes cauda equina, or a horse's tail. It looks like a horse's tail if you dunked it in a tube of water. And so there has to be obliteration of the spinal canal below that level for it to be cauda equina. So you have to have imaging findings consistent with it. And then you're going to have, kind of a lack of perianal sensation or rectal tone. They're going to have bladder, inability to contract their bladder, and so they'll have overflow incontinence. So they kind of won't really feel the need to urinate, and then all of a sudden will urinate all over themselves and have overflow incontinence. And so on the next slide, you'll see one of the things. Well, this is the imaging findings. So this is a patient with a large disc herniation at L5S1. So you can see normal discs above, well hydrated, hyperintense T2 signal within the central portion of the disc. Pretty, very, very healthy looking spine elsewhere, except for at L5S1. You can see there's not really T2 hyperintensity within the disc. And then there's a very large disc herniation that extends caudally. And on the right side of the screen, you can see the axial across that disc. And so there's absolutely no central canal anymore. It's taken up completely by the disc. This patient didn't really have very many leg symptoms, because you saw in the subarticular space, you'll see the two nerves, the S1 nerve roots on either side of that. And so those were already kind of exiting out. And so you didn't really have a lot of leg symptoms, but she had perianal sensation loss. She did have a high post-void residual around 700 or 800. There's some discrepancy in the literature. For me, what I tell my residents when they're on call is, I care about things greater than 200. So it's been shown that a post-void residual less than 200 has a 97% negative predictive value for cauda equina syndrome. So if it's higher than that, I start to get a little bit concerned. If it's 180s, things like that, there's a lot of different reasons for it physiologically for people to have that. So that's kind of a number to keep in your head. And then the saddle anesthesia comes from those S3, 4, 5 nerve roots, and that's kind of that perianal sensation area. And so that's why you get the perianal or saddle anesthesia that is kind of hallmark for cauda equina. So again, they don't always have to have leg symptoms. They can just kind of present with bowel, bladder symptoms and then this perianal sensation. So for these, it can be an emergency. The other piece of information when you're seeing these consults you have to know is the timing. How long have these symptoms been going on for? If it's greater than 48 hours, this becomes less of an emergent case, meaning that even if we decompress, this patient may not get full recovery, and that's been borne out in the literature. And so the timing is the other question you're going to get. Symptoms, imaging findings, and then how long it's been going on for. Those are the three things for this kind of consult. You have to know cold before you bump it up to your senior resident or attending. So for this patient, it was an L5 S1 laminectomy, did a wide laminectomy, removed that entire disc. You can see kind of reconstitution of the central portion of the canal, no stenosis. She's actually done really well, has had kind of full return of her bladder function, no numbness and tingling, that's residual. So kind of a win-win for her.
Yeah, I think the highlights for this is a great case because she had a normal motor and sensory exam because of where the disc is. So you can have cauda without any motor or sensory symptoms. So I think this is an important one to show. So it's easy to say no. Hey, this is not cauda equina, but would you have on here post-void residual is essential? Does every concern for cauda get a post-void residual then? Is that kind of a necessary test?
Yeah, if I'm truly concerned for it, yes. And when I say post-void residual, true post-void residual, and I think that's important for you to kind of parse out, and this is a good thing for you guys to know. I won't accept this person, we stuck a Foley in, and then when we stuck the Foley in, there was like 800 cc's out. Like, you don't know when they tried to go to the bathroom or anything like that. Or sometimes they'll try to have them urinate and then they'll do a bladder scan. Not very, especially in an obese patient, that's not very accurate. So you have to have the patient try to empty their bladder, then put the Foley in or a straight cath and see how much comes out. That's a true post-void residual rather than some of the stuff that they'll try to do in the ED.
Nice. All right, on to the last case. Again, another consult I can guarantee you will see as a junior resident. 55-year-old falls downstairs with neck pain and upper extremity weakness. So we've got the neuro exam here. Dr. Showery seems a little, unusual. Deltoids, biceps 5 out of 5, down to grip strength with nothing there. So what's on your differential diagnosis for this case? What are you thinking? You're muted.
Yeah, obviously the fall mechanism with acute onset is cueing me in a little bit. These other things that should remain on someone's differential when they're seeing these patients are things like transverse myelitis or, multiple sclerosis or other things that can kind of insidiously present with some, kind of weird upper extremity weakness. It's not consistent. I mean, obviously that's, in a setting where there's some acute trauma and neck pain, a little bit different, right? But this jumps out to me as a clear picture of a central cord, and definitely don't be confused and think that this is a bilateral acute carpal tunnel syndrome.
Yeah, I think a diagnosis that's critical to know, and then coming back to, I think JP said it in terms of knowing your exam cold when you leave the room. I think there's a tendency to not seek disease, and you kind of get the exam, they're older, they're not squeezing your fingers so tight, but the uppers are good. And then you look at the CT scan and this looks like a lot of arthritis, but I'm not really, seeing many fractures or anything like that. And it's, I think, very easy to say that we'll just kind of watch and this is nothing. But what do you see on the CT here that has you concerned, Sherry, that this may be more than just kind of a neck strain and Nana's a little bit weak and maybe needs a little pain medicine?
Yeah, what I see is that this patient likely has some component of congenital cervical stenosis, meaning just less available space for their spinal cord, and they have a lot of posterior osteophyte in the cervical spine, with a relatively, spondylotic cervical spine. Those are the things that make me think that there might be some underlying cervical stenosis that may have crossed the threshold to result in a spinal cord injury with this fall.
And then what are you seeing on this MRI now?
So MRI, we can see multi-level cervical stenosis, and you can see the spinal cord there at the 2-3 level, where there's significant spinal cord compression on this axial cut, and even in some, we can look at the spinal cord signal. Spinal cord should be homogeneous in signal throughout, and you can see here on this axial cut that there's a little bit of signal intensity, meaning kind of a brighter signal in the center part of the spinal cord, which is a sign of spinal cord injury or myelomalacia, if you will.
Nice. All right, JP, how are you managing a patient like this? I'm not seeing many fractures. She's got a little, the hands are a little weak, won't that just kind of get better with time? What's a management for a central cord syndrome patient?
Yeah, so central cord, it's an incomplete spinal cord injury, right? So it follows a very specific pattern, and that's based on the spinal cord anatomy and what was affected. And so pattern recognition of knowing that this is central cord, right? You have to think it's uppers more than lowers and distal more than proximal. So your upper extremities are going to be more affected than your lower extremities. Your hands are going to be more affected than the upper part of your like biceps, triceps, and deltoid, things like that. So one, understand what it is, and then two, how to best treat it. It is a spinal cord injury, so these patients, unless they have contraindications to it, typically will get MAP goals. So the mean arterial pressure, you want to have that up in the 80-85 range. Most of the time, that means a trip to the ICU, unless they're self-regulating their pressures. They get an A-line and they start that process. Steroids are controversial and not something we'll probably dive into in this component, but you want to treat this as an incomplete spinal cord injury. Sometimes these patients do improve, and so if they're kind of rapidly improving over an hour or so, you can kind of watch these injuries. But if they're not really improving, especially if they're worsening over time, the goal is get the pressure off the spinal cord. And so for this particular patient, he was a narcotic user, he was a smoker. There's a lot of reasons you don't necessarily want to do a huge fusion procedure for him with a laminectomy, and so choosing a smaller laminoplasty procedure that with dome laminectomies above and below accomplishes the goal of decompressing that spinal cord and hopefully mitigate some of his risk factors for a poor outcome in the future. And that's what he got here. So he, I think did really well and had near resolution of his weakness, which a lot of times can happen for the central cords if you jump on him relatively quickly.
So if a resident presents one to you, will you have them, check them again in an hour, see if they're getting worse then? Is that?
Yeah, so yeah, exactly. I think the severity of the neurologic injury at the onset is a portion of your decision-making process, right? So if there's zeros, you're not going to really wait around for that patient. But if they're threes, fours, and kind of improving, that may be somebody you can kind of watch. Realistically, right? I mean, in a spine emergency, they come in with an incomplete spinal cord injury. You're quote unquote rushing to the OR. Realistically, you're going to get in there in an hour and a half, 2 hours, something like that. So yeah, I have my residents evaluating these patients serially to see if there is improvement in the interim while we're waiting for that. I would say it doesn't typically change what I'm going to do though.
And if it's missed, can it progress to a complete injury then if Nana sits overnight or doesn't get picked up? What will be the negative of that?
Yeah, definitely. I mean, it can be an evolving spinal cord injury, right? So it presents with a certain amount of weakness and it can progress as the edema in the cord kind of propagates. And so it can go both ways. It can improve, but it can also worsen too.
Yeah, I think a scary injury in a lot of ways, but one to have your antenna up for sure. So just to sum it up, the most common incomplete spinal cord you all learn the anatomy of the tracks and things as a medical student. It does end up being pertinent as you're seeing people in the emergency department, particularly these elders who have a very classic exam. So sum it up for us. I'm going to start
Quick
with
question on that, Phil, just real quick. If this patient comes to clinic with some slower onset symptoms, how urgent is that versus the acute traumatic, clearly tipped over the scale by the falls?
Sure. So the difference is an acute spinal cord injury versus like chronic myelopathy. So your spinal cord actually tolerates compression pretty darn well if it's over a very long, slow period of time. So the abrupt changes or distraction your spinal cord hates. You'll get severe neurologic injury with either an acute trauma or distraction through the cord. Slow compressive pathology, it actually tolerates pretty well. And so it's not uncommon to see these patients with edema, T2 hyperintensity within their spinal cord, severe central stenosis, and they show up in your clinic and they're 5 out of 5 strength. So knowing the difference between a central cord, which is a more acute process, with pre-existing central stenosis, so a small low energy extension injury can perpetuate a pretty acute onset incomplete spinal cord injury versus a much slower pathologic process, which your spinal cord tolerates, and they don't necessarily show up with extreme weakness, but they describe clumsiness in their hands, gait instability, maybe some slower or some slow movements, and then positive Hoffman, some of the long track signs, reflex signs that you're going to see. That one, yes, you can wait. It's not an emergent. You don't admit them from clinic necessarily, unless again they're kind of acutely decompensating over the last week or so.
Nice. All right, shall we? Final tips, final pearls for spine as they're heading downstairs and seeing these injuries. Mute. Shower, you're muted, buddy.
I did it again. Yeah, I think that this slide really summarizes this well. So, importantly, just know your anatomy and develop a system for how you do it. Systematically reviewing the CT scan, systematically reviewing the MRI, and being consistent about how you do it so that you don't miss things, right? You want to have a complete picture. And if you have an incomplete picture, it can sometimes send you down a pathway towards working the patient up or proceeding towards some intervention when you really needed to take a different approach. Obviously, these stiff spine fractures are highly unstable and can be very, very subtle, and it's important to identify it. Getting a detailed neurologic examination and really, really understanding, like comprehending what you're doing when you're doing the exam is important. And obviously, like, load the boat. You don't want to be. You're not an island. You're not going to be able to. Each and every one of us knows that it's a big team that takes care of these patients, and the more you get involved, the more you bring other people along with you for this ride, the better it's going to go.
JP, anything to add?
No, I mean, just kind of what we talked about. Do the work ahead of time, read, know your anatomy, review imaging ahead of time, and then when these consults come in, if there's neurologic injury or there's going to be trepidation initially, but take a deep breath, fall back on your system, fall back on the protocol that make that second nature to you. And if you do that, everything's going to go fine. You're going to help a lot of people, and you're not going to miss injuries. So spine's not some big black hole. It's just it's a little foreign to people, and it just needs some getting used to. But you all get there for sure.
I think opportunity for med students is all kinds of neurologically normal people in your life, and you should be practicing your exam on them, right? Maybe not the more intimate parts of that exam, right? But like in general, as a med student getting into this, like what you should be doing is examining patients, as best that you can, so that you can get an understanding of what the normal spectrum of what people will be, right? My 5 out of 5 is going to be different than like, an 80-year-old lady, right? And there's going to be a huge difference in each and every person that you see, and how you grade that and how you think about what you're seeing and understanding it is just something that comes with experience and practice.
I thought you were about to call out JP and say my 5 out of 5, much different. So Taylor, any final questions there?
No, we're all set. Everybody,
Yep.
we appreciate you guys answering, asking a lot of questions, and then James was answering a bunch of them, so that was super helpful.
We have nibbled on just a tiny portion of what spine is, but I think these are undoubtedly the 5 consults most common to be seen as a medical student or a resident. So there's a fair amount of information there. I'm so grateful for both Dr. Showery and Dr. Weiner for y'all's wisdom as you're working through it. I learned a ton, and I think Dr. Aker did too. So next month we're doing distal radius and forearm fractures. So back into the trauma world a little bit. And then a reminder, next week, this special session, we got some program directors who'll be joining us to talk about some tips and pitfalls with your residency interviews. And whether you're a 4 currently interviewing A 3 going to go on away rotations next year and interview at your away rotations. A 2 or a 1, considering what field you're going to go into. I think everybody would get a ton out of this session. It's going to be very interactive, question answer, and it'll be great. 1AO is a meeting that's occurring this April in Henderson, Nevada. So I just wanted to plug this as well. The registration's open. I am going. Tim, you going?
I'll be there.
Taylor?
Phil, first time, Phil.
Here we go. So it's
Coming to the Southwest.
Yeah, I'll see you there, buddy. And so thank y'all again. Check your email for your Credly badge, and this will be on YouTube.